Hi, hello, good evening, everybody. Warm welcome from the Global Dental Professionals Organization to all the curious listeners and participants, as well as our esteemed speaker. So I would like to start with a quote given by Matshona, which says, if the work is good, it will speak for itself. But this gentleman's work is, this gentleman's work is so loud that it will scream for itself, and so much so that the ripples of the his success stories have reached not just to Bangalore, all the way from Mumbai, but all across the globe, from Riyadh and UK as well. So I'll pass on the reins to Dr. Tofiq Bohra directly without wasting my time. And Dr. Tofiq, you can go ahead.
Thank you, ma'am. Thank you for the wonderful introduction. My name is Dr. Tofiq Bohra, and I practice in Mumbai at SL Raheja Hospital. I have completed my fellowship in TMJ Arthroscopy and Total Joint Replacement from University of Maryland, TMJ Mini Residency. Thank you, ma'am. Thank you for the wonderful introduction. These are my affiliations as of now. And I have done a certification in pain from the British Pain Society. And also I am a 2B member in the American Society of Temporomandibular Joint Surgeons. Coming to the current topic, temporomandibular joint disorders, a different perspective to the same problem. I per se would not claim to be a pundit in the field, and I do not want to talk about the entire scenario of TMJ disorders, but yes, I will be discussing my experience today with working in this field, and also that at the end of the day, TMJ is a joint in the head and neck region. It is the only joint we have in the head and neck region. We as dentists and head and neck practitioners should also look at the joint from an orthopedic standpoint and also evaluate the joint from an orthopedic opinion. Look at it like an orthopedic and a dentist, not like only a dentist. So going ahead with it, from what do we expect from our talk today? We will brush up the anatomy and the function. Majoritarily, we'll be talking about the biomechanics and the adaptability of the joint, how it works. What are you looking at in the joint? What is the biomechanical scenario of this joint? TMJ internal dearrangement and the orthopedic principles applied, the diagnosis module, the modes of diagnosis, what are the treatment options? Oromandibular dystonia has been included by me because I've treated it's a very rare disorder, and I wanted to include it in my talk today because yes, when you start in the field of TMJ, eventually you realize that it is no more temporomandibular joint disorders. It is going and having extensions in orofacial pain as well. And then we'll discuss a few case scenarios put up by my team, and we will discuss it. We'll take it up like a panel discussion. So anatomy, let's get things into perspective. This is the joint, and the joint is composed of an articular eminence. We have a glenoid fossa, we have a condyle, we have the lateral pterygoid muscle. However, I would like to say that the other image on the left for me is slightly an anterior displaced disc, but yet it is a very good image. I would like to point out the lateral pterygoid muscle over here at the anterior portion, how it splits into two parts. The lower half of it is attached to the pterygoid fovea of the condyle, and the upper is attached to the disc. This is important to understand from the biomechanical standpoint that the initial movement of the TMJ happens in the inferior joint space, which is purely rotational. And what happens in the upper joint space is when the superior fibers of the lateral pterygoid are activated and they pull the disc forward. Talking about the disc itself, the disc is composed of dense fibrous connective tissue, and it is devoid of any blood vessels or nerve fibers. However, it has been seen that the periphery of the disc is slightly innervated, and that is also a contributing factor to capsulitis, actually. And the disc is obviously, as you can see, it is a biconcave shape. We all know about it, the anterior band, the posterior band, and we have an intermediate zone of the disc. The intermediate zone is the accommodating part for the condylar head. In a normal scenario, this disc is placed between the articular eminence and the condylar head. I would also like to mention one thing over here, that unlike the knee joint, the TMJ joint has a fibrocartilaginous disc. This is an important point I wanted to highlight. The meniscus in the knee is hyaline cartilage. We have a fibrocartilage which is much more robust and has higher adaptability capacity, as researched and mentioned by Okeson in his book. Going through the muscles of mastication, just going through briefly, we have these major muscles involved in the opening and closing of your mouth, and also the reason where when there is a problem in the joint, myogenous component of the pain is much higher than the joint itself. MPDS, what you call, the patient complains of pain, stiffness. We will talk about it. But these are the muscles. However, here there is one muscle which is not mentioned. That is, I think the digastric muscle is underrated. It also has an important role to play in the TMJ elevation and depression. These muscles, you have to understand that these muscles undergo cyclic loading and unloading. So hence I emphasize on the point of biomechanics of this joint. Because if something is wrong in the biomechanics, everything takes the brunt of it. I just wanted you to have a look over here at the disc. You need to look at the translatory movement, the lateral pterygoid muscle pull, and the trajectory of the muscle. This is a wonderful video made by the Anatomy app. There is an app which makes these 3D videos. I would like you to note the lateral pterygoid muscle is attached to the splenoid, and it has an anteromedial attachment to the disc. And hence, the most common disc displacement you will see will be an anteromedial disc displacement in your MRIs. Quickly coming to biomechanics and adaptability. Biomechanics is the application of mechanical laws to the living human structure, specifically the locomotive system of the humans. Therefore, biomechanics concerns with interrelation of skeletal tissues, muscles, and the joints. Now, how is biomechanical stability so important? Biomechanics. Every orthopedic is trying to achieve biomechanical stability in the joint. It is basically the harmony, and in our joint, with respect to TMJ, it is harmony between the joint, the internal joint environment, the muscles involved in opening and closing, and the teeth, the occlusion, the place where the bite force develops. Okay. Whenever consider this as an equilateral triangle, where the patient, when he or she comes to you, will always come with, just give me a minute. He's going to always come with either pointing out the TMJ, pointing the muscles. They will be coming with a parafunctional habit. And also, I don't think very rarely a patient comes and would say that, doctor, I have a malocclusion, and that is why I am having this problem. Most of the time, they are aware of a click pop in the joint. Most of the times, they'll be talking about stiffness in the muscles, in the face, mostly in the morning times. And they will be aware of clenching, bruxism, sleep bruxism, day bruxism, these kind of factors. But rarely they will complain about their occlusion. Dr. Gausia?
Hi.
Is there a way I can take this column down? I think it is hindering in my presentation.
Yeah.
Can you see the entire slide or this column?
No, we can see the entire slide. We can see the entire slide.
Okay. Okay. So yeah, moving forwards. Excuse me. So now talking about the synovial fluid part of it. I don't know why people do not talk about synovial fluid, but in this presentation, I would like to dedicate this entire slide to synovial fluid, because synovial fluid is the only medium for exchange of metabolites, and it plays an immensely important role in joint function. Synovial fluid lubricates the articular joint but the way it lubricates, it has two types of lubrication. One is boundary lubrication and one is weeping lubrication. So what it says is boundary lubrication is from the periphery of the disc. When the disc, the disc develops, generates synovial fluid, and it forces the fluid from one area of the joint to the another. That's boundary lubrication. Weeping lubrication refers to an ability of the articular disc to absorb a little amount of synovial fluid. And when the joint is under compressive forces, it releases that fluid. Okay. So it lubricates in that manner. Now, when does this happen? This happens when you have taken a bite. Okay. So technically, for example, if you are eating something from your right side and you take the first bite, there is a working condyle and then there is a balancing condyle. Compressive forces are absorbed by this disc and at that point of time, it releases the synovial fluid. These forces, and now why do I mention this point with so much emphasis, is that if these compressive forces are constantly active inside the joint, then the disc will stop creating this lubricant fluid. And when this happens, when the lubrication of the joint comes down, it leads to biomechanical instability. So synovial fluid has a very major role to play in the biomechanical stability of the joint. This is Hilton's law. It was brought to our hold on a minute. Yeah. So this is the Hilton's law. It was brought to our knowledge by Dr. Mercury, who has been our trainer in the TMJ mini residency. The nerves that innervate the joint also innervate the muscles that move the joint as well as the overlying skin. This is absolutely important to understand. Over here, which nerve are we looking at? We are looking at the trigeminal nerve. So the trigeminal nerve is basically innervating this entire area. And in specific, we are looking at the auriculotemporal nerve. Why is this law important to understand is that this is the law, it's a feedback mechanism which causes guarding. So when these patients say that I typically feel stiffness in the face, it is because of Hilton's law. Most of the pain these patients complain is they talk on the neurological pain line, and that's because of the Hilton's law. By means of analogy, if I have to explain, if somebody has a bad joint, or bad knee joint, say, in the morning they get up, they feel stiff around the joint because the muscles are stiff so that the patient does not move that joint a lot so that they can have rest in that joint. That is precisely the meaning of Hilton's law. And this is a very important law from this biomechanical standpoint. This is a slide from Dr. Tanaka and Dr. Mercury's slide. Now, looking at the top left corner, let's talk about adaptive capacity now. Okay, when the joint is under normal load, okay, there's functional remodeling happening, there is adaptive capacity, the articular disc is doing well. Consider a scenario when the host capacity of adaptation is decreased, or you may say the mechanical load or the load coming on the joint is increased as compared to the adaptive capacity of an individual. What happens is dysfunctional remodeling and it leads to an abnormal cartilage. What are these mechanical factors? They're mentioned over there. What happens is this abnormal cartilage leads to hypoxia. It will lead to these full cascade of events, which we know as cytokines present inside the joint. Most of the times we say them as inflammatory mediators in our language that eventually lead to cartilage breakdown. This is something which I think there is no controversy regarding this etiology chronology. So I think this is very well accepted and this is how it happens. This is something which is made by me to emphasize on the synovitis part of it. So consider mechanical stress, parafunction, disc displacement, joint overload, trauma, everything leading to biomechanical unstable joint, which will also include a disc displacement with reduction, which leads to synovitis, adhesive capsulitis, and also something called a synovial plica, which in turn will lead to impaired lubrication, which will lead to limited mobility and pain to the patient, osteoarthritis and cartilage degeneration, which can itself increase synovitis. And eventually, everything from this leads to Hilton's law and a guarded biofeedback response from the patient. The patient cannot open the mouth. We are talking about the biomechanical stability standpoint. We are discussing the disc and its interactions in the entire joint. Consider this video over here. You see, this is a clicking disc, but it is clicking with reduction. So whenever the patient is opening the mouth, there is a reciprocal click happening. And when the patient is opening, the click is coming right on the head. But when he closes, the disc displaces again. For me, when I look at this joint, this disc is functional. It is very well functional, but it is acting as a speed bump. When this happens so many times that it leads to an inflammatory joint, that's when it leads to a domino effect. Everything starts happening. And imagine this disc is not right at the head of the condyle. So it is even not going to lubricate the joint well. And that's where synovial fluid also comes into picture. You remember this triangle, TMJ, muscle hyperactivity, occlusion. This is what is we are aiming at. Coming to internal dearrangement, talking about the disc positions. We have a normal disc position. Then we have an anterior disc displacement. This is just one scenario. The disc displacement can happen in multiple vectors. That, as I said, anteromedial being the most common, anterolateral. There can be a posterior disc displacement as well, but posterior disc displacement is a rare phenomenon. Mostly it is anterior. It may be anteromedial or anterolateral. Anterior disc displacement with reduction will, as I showed you in the previous video, the disc, when the patient opens the mouth, when there is translatory motion happening, the disc will reduce back to its original position. But when he or she closes the mouth, it will again displace. And then there is something called as anterior disc displacement without reduction. Normally, without reduction means the disc is not coming back to its normal position. Now, as you see in this image, imagine a patient with an anterior disc displacement without reduction. What is the clinical scenario of this patient? This patient is completely loaded on the retrodiscal tissue. Okay. So the point of movement is not the disc anymore, it's the retrodiscal tissue. This is the main reason where the inflammatory cascade begins. This disc moving forwards, because it is displaced, is completely folded, okay, and is not covering the condyle. I'll also like to point out one more thing. The lower surface of the disc, which covers the condylar surface, has the chondroprogenitor cells. Now, this is something very histological in nature, but it is important for me to say this. Why? Because we constantly hear that the condyle will remodel accordingly. There will be a lot of remodeling happening inside the joint. This remodeling happens in a best case scenario when the disc is sitting on the head of the condyle, because the lower surface of the disc has these remodeling and adaptive cells. If you see the last image, the condyle is riding on the retrodiscal tissue. Now, when you try treating this patient with a non-reducing disc with conservative methods, you may achieve healing, but that is just going to be scar formation. The tissue will heal and it will form a scar. Moving ahead. This is the Wilkes classification of TMJ disease. We all probably have heard about this classification. Yes, it says a lot in the initial levels, but it only talks about the position of the disc and how it is placed. Not really complete in its own self, but yes, it is enough to come to a basic level of treatment. We have stage 1, stage 2, stage 3, stage 4, stage 5. I would say that in our clinical scenario, I don't see any patients coming to us in stage 2, let alone stage 1. So as clinicians, as dentists, you will be coming across a patient probably in an intermediate stage of Wilkie's classification, who will be having something of what it is mentioned in that column. What does ID do? Why is internal dearrangement talked about in so much detail? So in a crux, just to summarize, clicking, it causes clicking and popping. Clicking and popping causes muscles to be in a constant state of adaptability, because yes, they have to compromise for whatever has happened, and they will try to maintain that biomechanical stability. So they will be in constant state of adaptation. When the situations progress, you will see reduction in mouth opening and inability to chew. Obviously, the chewing function will get affected. Headaches, you will see headaches and referred pain. Eventually, it will turn into a musculoskeletal pain problem. Now, looking at the right hand side, what is more important? Is disc position more important in a joint, or a functional disc is more important? What should be given more priority? According to the classification and according to the previous literature, disc function is more important than disc position, because you will see a lot of people with a disc displacement who are asymptomatic. You can link it to the previous slide I showed you, that is about adaptive capacity. Probably the patient has adapted to the position, but you add a parafunctional habit to this patient and he will start having those symptoms. So we have all heard, and as all dentists, we know that a patient comes for a third molar extraction, as maxillofacial surgeon can perform that third molar extraction, and immediately from the next day, this patient starts complaining about his TMJ. Because yes, the maxillofacial surgeon put load, and there was already an underlying condition which just got exaggerated with that procedure. Now, this is exactly what I mean, that yes, a functional disc is mandatory, but disc position is also important. Why is disc position important? Because disc position, when not addressed, will eventually lead to change in disc morphology, which is an irreversible scenario. The moment the disc morphology and the bone morphology changes, that is an irreversible scenario. And now achieving biomechanical stability in such joints will be extremely difficult. Burden of diagnosis. The word idiopathic. Idios means one's own and pathos means suffering, a disease of itself. Normally, we are faced with this burden of diagnosis when the patient comes to us in a clinical scenario. He or she will present with multiple clinical symptoms, including the psychological aspect of it. I mean, this patient probably will be crying in front of you. So, in my humble opinion, sometimes obsessing about the root cause, why this happened, does not really mean fruitful. Yes, it is necessary to make long-term changes. You need to know about it. But in my opinion, initiation of treatment sometimes clears the fog, because there are a lot of overlapping signs and symptoms in this patient. And sometimes knowing why it happened in the first place is very little help to the treatment plan. I mean, if I had to explain with a way of analogy, somebody has a block in the heart and he goes to a cardiac surgeon. The cardiac surgeon, rather than pondering over why he had the block, will have to treat with the problem at hand. So he will first start the initiation of the treatment. And then, yes, obviously, the lifestyle modification, finding the cause, why did this happen in the first place? Because when this patient will come to you in your OPD, it's not necessary that he or she will say all the history, because the answer to this question lies majorly in the history of this patient. They might say that, oh, I fell down when I was 5 years of age, or yes, my husband has noticed a parafunctional habit, or my wife has noticed a parafunctional habit. So you first need to start with the treatment. How would you test a patient if you want to actually start with this? So Mahan test is something which I'm sure you guys might have heard about it. This is a loading test, basically. So how you can do it, this is a very simple test. You can do it at your clinical setup. You just put a tongue depressor or something like a backside of a tweezer. You can ask the patient to bite on it from one side. If the patient points on the same side, complains of pain on the same side, then it is a muscular component of pain. It is more myalgia than an interjoint problem. And if the patient points on the contralateral side, that side is loaded when he or she is doing this activity. And if he complains of pain on the contralateral side, this shows that there is an intrajoint problem. There is joint inflammation. If you ask me personally, trigger joint blocks and intrajoint injections, local anesthesia block injections, they work for me. I do them routinely in my practice, and they are an immediate way to understand what is happening over there. However, it is not very clear because yes, it does over the time anesthetize the entire area. And yes, it requires a little bit of regular skill as well. But if somebody wants to give it a try, you need to ask the patient to open the mouth and then direct your needle anterior superiorly towards the eminence of the patient. You will hit bone and then you can deliver 1 ml of fluid inside. That does two things actually. It helps in two ways. You are delivering the local anesthetic. Above everything else, you are also encephalating the joint, which is going to bloat the joint and also increase the joint space simultaneously. For me, MRI is gold standard. Okay. Now, there are a lot of people who do OPGs and CBCTs in the initial stages to understand how it is and what it is. However, for me, OPG and CBCT most of the times comment on the bony surfaces of this problem. Most of the times, most of the cases, bones will not be a problem. It is always the soft tissue component which is having the problem. So what happens is you get a CBCT done. Yes, it will show a collapsed joint. It will show decreased joint space. Eventually, if you want to go ahead with any kind of concrete treatment, you will have to ask for an MRI. So I would like to put it across that MRI is gold standard for any kind of, and not only TMJ. MRI is, even if you sit with the orthopedics, they will always prefer an MRI over any other scan. Coming to the treatment options, in diagnosis part, I'm missing the slide, but since I'm talking about it, I would like to mention a point. Even serology plays a role. So if you have it at your disposal, why there is not a slide is that actually serology is difficult to find because ANA test, rheumatoid arthritis, and HLA are the three which are the serology conclusive to point about juvenile arthritis, rheumatoid arthritis, induced new arthritis. These are basically the serological tests you can do. But frankly speaking, even in my scenario where we work, these tests are difficult to perform. So not everybody would have access to these serological tests. But yes, if you have access, you can get this basic workup done along with an MRI to come to a conclusion. Going ahead with the treatment options, there are an array of treatment options, and this is where there is actual controversy in this field, that how do you treat this particular problem? Okay, we know that there is a problem. How do you treat it? So we have a lot of fields overlapping: orthodontists, neuromuscular dentistry, splints. We have surgeons coming in with all kinds of different surgeries. But then how do you proceed? First things first, you need to reassure this patient that this is not a life-threatening problem. Yes, it is a life-altering problem, but it is not a life-threatening issue. So it will resolve. It may take time, but it will resolve. We will manage it. We never use the word cure in any patient that we talk, because the muscles, the teeth, and the joints are always going to be there. You cannot remove and throw them off. The moment you talk about removing the joint with me, I will put in an artificial joint over there. It will come with its own set of problems. So there is no cure. It's managing, hitting that sweet spot, achieving hemostasis. You can advise the patient for heat applications in the initial level, NSAIDs and muscle relaxants. Do the job in initial stages. I'm sure you guys know about it. Anxiolytics. Anxiolytics is something where the pain medicine comes into picture. So anxiolytics, predominantly you look at alprazolam, diazepam, and the SSRI group of drugs. SSRI is serotonin selective receptor in uh, uptake inhibitors. Sorry. So basically, these medicines, they do two things. They decrease the anxiety level of this patient, because yes, this patient is going to be anxious because probably you are the 10th doctor he or she is visiting, and they have already been to ENTs because that's the first place these patients normally go. They might have, from the ENT, they might have gone through an array of tests. They might have gone to a neuro for the neurological aspect of it. After that, the neuro might have made a comment that, okay, this looks like some dental issue. Why don't you visit a dentist? And that's when this patient is now all confused and ghosted about the problem and cannot find a solution. So yes, anxiety levels are high. So anxiolytics do work. SSRIs are known to be acting on the pain cycles. Basically, there is an ascending pain and the descending pain cycle. They do work on that, and they also change the perspective of the patient towards the problem. In the world of pain medicine, there is a term called as catastrophizing the problem. Catastrophizing the problem, the catastrophise is a big word. What it eventually means is that the patient normally starts feeling the problem to be more big than it actually is. That's called catastrophizing. These medicines help in that aspect of this patient. However, they should be used sparingly, and that's the reason why it is in red. That you have to understand who you are prescribing to and how you are prescribing. There is a regime to do that, and I would normally ask that if you have little knowledge about it, refrain from using it. Ask the specialist or some guy who has knowledge about it to prescribe these medicines. But these medicines do have a role in the pain management aspect of it, and that's why I felt it important to mention. Coming to the array of other treatments available, we have now the first thing is what I prefer in my treatment module. That's a stabilization splint. Stabilization splint. Then we have orthodontics. We have removal of occlusal interferences. We have pharmacology, pain management. We have physiotherapy. This is all the conservative part of it. Then comes the surgical and or you may say the minimally invasive part of it, which is arthrosynthesis, arthroscopy, prolotherapy with dextrose plus bupivacaine. This is specifically for subluxation cases. It is told to induce a little amount of fibrosis and will help in hypermobility of cases. However, Botox is something which is also used. And well, if you ask me, being trained in arthroscopy, I would prefer to give Botox under vision, putting the scope inside and directly going and injecting in lateral pterygoid rather than doing it blindly and not knowing where the Botox is actually going. So yes, that is something. You can also use Botox in the masseter muscle and the temporalis muscle, which are the immediate muscles which are the immediate muscles who are under the cascade of hyperactivity, if I may put it across. Then yes, the traditional open joint disc repositioning with a screw anchorage, open joint discectomy. Nowadays, we have recently started with laser discectomy. So we do not open the joint. We put in arthroscopes. We put in our laser through the arthroscope, and we can perform a full-blown discectomy procedure. Discectomy means taking off the disc, removing the disc in entirety. And the last is the total joint replacement. We replace the joint. I'll be talking about it when I come to that slide. Talking about the stabilization splint, I personally do not make these splints. We have a specialist doctor, Dr. Saurabh Shah, who does the needful for us. But I know what he does normally. So I know a lot of people considering a hard splint as a stabilization splint, but it has to be made in a particular manner. As dentists, this is something which we need to understand, that face bow transfer is absolutely mandatory. So when you do a face bow transfer and you see the lateral contact points, so what does this stabilization splint mean? And normally what we try to achieve is we try to achieve disocclusion of the teeth as soon as the patient tries to move right and left. Okay. So this is typically very important, because what it does is it will, as soon as the patient, for example, if this patient has some parafunctional habit and tries to move the jaw, at least all the teeth are not in contact, and which breaks the continuity of the bite force. The other thing that this splint obviously helps is maintaining the joint space. Consider a patient with a displaced disc, the joint space would collapse. This splint will help in maintaining the joint space. It may not increase the joint space, but it maintains the joint space, which will in turn give time for the disc or the retrodiscal component to heal. So the image to the right hand side is a deprogrammer. This was particularly given by Dr. Saurabh to a patient where this patient post arthroscopy, I sent it to Dr. Saurabh, and the patient was on aggressive physiotherapy. Now, when this patient started doing aggressive physiotherapy, his one side lateral pterygoid muscle went under severe spasm. And the next day, what we saw is his jaw was completely deviated towards the side the muscle went under spasm. And this happened post-scopy. So what we requested Dr. Saurabh is to give him a splint, which will act as a deprogrammer and take the load completely off that particular muscle. And yes, as soon as we did that, the patient's muscle relaxed. We had already planned that if this would not work, I would have to use Botox and relax his lateral pterygoid muscle. So that's how a deprogrammer works. This is a small video to show how he does it. This is the centric position of this particular patient. Now, whenever they move to the right and the left, the anterior plane basically disoccludes these teeth. And that is what we try to achieve in all these patients, that as soon as they have this lateral shift of the teeth should disocclude. Lateral movement, this is I think this is an immediate post-op thing, and that's the reason why the lateral movement to the right-hand side of the patient is a little compromised. So let's discuss this image now. What happens? I mean, yes, the disc, we have the splint or the orthotic or the hard acrylic stabilization splint in place. What do we aim? What do you achieve with conservative treatment? So what it does is, as I said, it will prevent collapse. It will not allow this joint to collapse completely on the retrodiscal tissue. It will help to induce scar formation. Yes, it will reduce the muscular activity, but does it really recapture the disc? Now that's the point where the controversy comes in. So now a lot of people have this belief that when this scar tissue will form, it will pull the disc back. All right, but it is a long shot. It is not that easily done. Why is it not easily done? What happens? The challenges that you face actually is that this requires a long-term patient compliance. You are dependent on the patient wearing that splint. As soon as the patient remove the splint or he is off the splint, he is again loaded. The joint is again loaded. There has to be calibrated load distribution. That means this patient has to visit you at least once a month. And you will have to calibrate his splint because yes, as he's using, if he's a normal user, okay. But imagine him to be a bruxer or a clencher. There is going to be constant wear and tear in that splint, and you will have to actually calibrate it. From our standpoint, there is no active remodeling happening because the disc is displaced. It's not in position. So there is no active remodeling happening over here. What is happening is just scar. Above everything else, the lubrication of the joint is coming down. The joint lubrication has significantly come down and is adding to the adhesions and the fibrosis inside the joint. So why am I specifying this point? Because there are going to be adhesions between this disc and the bones and the joint. These adhesions initially are superficial adhesions, but with time they become fibrotic bands. So here comes the point that, okay, what happens if you are giving a steroid injection or you perform a small arthrosynthesis procedure, but arthrosynthesis cannot lyse these fibrotic bands. And if there is no lysis happening, probably there is not going to be any recapture happening in this patient. So how does this splint help? It breaks the circuit, it increases the joint space, helps in healing the foreign object effect. So there is a study which states that whenever you put a splint in the patient's mouth, the patient becomes really aware of his or her condition for the time he wears the splint, and objectively tries to work towards not doing what he or she is normally doing. That means clenching, bruxing, moving the jaw multiple times. They are aware of a foreign object inside the mouth, and they consciously avoid doing that. This study to the right of mine is especially mentioning that. And if I read the conclusion for you, the both splints reduce the masseteric EMG activities associated with the stabilization splint. However, the effect was transient. SB means sleep bruxism, sorry. However, the effect was transient. Why was the effect transient over here? I read this article. When you read the article in complete sense, what it says is that the muscles and the patient adapted to the splint. So once it was a routine for them, the EMG activity again started increasing. And then we have this article from a fellow senior colleague of mine, Dr. Darpan Bhargava, who has recently concluded in his article that the use of oral orthotic and occlusal appliances should be based on current available scientific evidence rather than archaic protocols. Archaic protocols, what he's trying to say over here. And this study is as recent as it gets. It is a 2023 May study. So it is the recent most study, and it has been published in Oral Maxillofacial, in the Journal of Association of Oral Maxillofacials of India. And archaic protocols means what they're trying to say is that something which we have been doing since a long time, we just do it because we know about it and it's more convenient for us. So it has to be evidence-based, basically. When does conservative treatment actually work the best? The conservative approach works the best in recent temporomandibular joint disorders. That means a very acute patient coming to you in the recent first 6 months. The disc is still functional. It is the disc is functional. It is still reducing. It'll allow the joint to adapt. There is no change in the disc morphology. Post arthroscopy, yes, it has a very evident use in maintaining the the biostability of the joint. And in the cases where it is purely myalgia, this patient has a normal joint, everything has come normal, but yet there is muscle pain. In those scenarios, if you give the splint and you take the load off this muscle, yes, it does make a huge difference in these patients. However, you have to understand whether it's arthralgia or purely myalgia, and then only it will work. TMJ arthroscopy, this is something what we do, we perform. I specialize in this. The apparatus what we use is we use a 1.9 mm scope, which is I have two scopes. One is from Carl Stores and one is from Endoluke, and these have been used in a 3-chip mechanism system, and it's a 30-degree scope. When I say a 30-degree scope, means we have scopes as 0 degree and as well as 30 degree. That's the angle at which we view the joint. Technically, arthroscopy means putting a small camera inside the joint. Mostly it's in the superior joint space compartment. And then you also can introduce a second port in the same compartment under vision, and you can perform the surgery. What can you perform? We'll be discussing in future slides. This is how you put the instruments inside, and you can also pass a stitch through the disc and anchor the stitch. That's a level 3 arthroscopy. Moving forwards. This is a case that we performed. You can see this is the synovial plica, and if you can appreciate that it has its own blood supply. So this is something which is not normal. Okay, it has developed these small branches, and that is the creeping synovitis, what we talk about. So technically speaking, when you enter a normal joint under a scope, it has to be completely white. It has to be covered with synovium, which is absolutely white in color. And these red tributaries, what you see, the capillaries inside this joint, these are the source of inflammation. This is inflammation, and this is how the cytokines and inflammatory mediators are communicated through the joint. So this is an earlier case of mine where I used to use mechanical instruments like the graspers you see using me. We used the graspers, we clamped the plica, and we tried to clear this patient's joint. As soon as we did that, the patient was pain-free, and this patient was managed by me initially with using endoscope. This was confirmed earlier with an MRI, and then he was referred to Dr. Saurabh for due maintenance of his disc position and condition. This is one more video I would like to point and show it to you. This is post-reduction. Can you see the white on white surface? The upper portion is the eminence and the lower portion is the disc. This patient, the other two pictures over here, you can see this inflammatory vessels going up through the retrodiscal band, the superior retrodiscal band. This is creeping synovitis. This is the inflammation you talk about. You see this? That's all through the roof. That's the posterior band. This is coming across, and that's the disc. That's movement. That's the area of the disc which was which is loaded. This is how we manage with laser. You can see everything is red inside the joint, and there are a lot of adhesions and floating substances. This is typically a Holmim-Yag laser. What we use this laser to ablate the joint. What we do with this is all these tributaries which are present inside the joint, we coagulate them. So technically, when we ablate this, it immediately resolves, and this will also induce a little amount of scarring over there and will help in advanced healing of this joint. That's the fiber of the laser we can put inside. It's an Holmim-Yag laser. This is one more arthroscopy video. I would like to show it to you because this is classically how it clicks. Can you appreciate the joint moving? When I move the joint, when I open, you can see the click. See, the disc is popping in and out. This is how actually the disc looks when it clicks, and we ablate the entire area using the Holmim-Yag laser. As of now in India, we do not have a probe that holds the laser. So we had to use all the sticking methods to hold the probe and create an artificial probe. So this is me ablating those vessels and coagulating them. It's like an eraser. You see those red lines on the disc, and you use an eraser and you can just wipe them off. it works wonderfully. This was to cut the adhesion basically. So we actually went through the disc over here, just posterior to the disc. This is the retrodiscal tissue. All right. Now, what does arthroscopy do? Arthroscopy will allow flushing out of inflammatory mediators and the pain mediators. Arthroscopy will allow you to reduce the disc under vision. It enables the surgeon to perform pinpoint Botox injections in the lateral pterygoid muscle. It also will allow you to perform adhesiolysis using scissors, or if you have lasers along with you. Arthroscopy will allow you lateral pterygoid myotomy. Now, this is very important to understand that the lateral muscle myotomy works really well in chronic cases. Because now when this patient, chronic, when I mean chronic is more than a year, will develop a muscle memory in the lateral pterygoid muscle. So now when you go and try to reposition the disc, the muscle memory will kick in and it will again displace the disc. In such scenarios, when you perform a lateral myotomy and you anchor the disc via a suture arthroscopically, it helps in maintaining the position of the disc and further relapse. Arthroscopy nowadays, in these current scenario, also helps the surgeon to perform an eminectomy, lateral eminectomy specifically. We have small shavers. So they are used to shave the bone and you can get rid and increase the joint space. We earlier, for performing an eminectomy, the oral maxillofacial surgeon used to open the joint. Nowadays, we can do that pretty much via an arthroscope. Coming to traditional open joint surgery, we've been performing a lot of these. This is how the click happens in an open joint procedure. This is a preauricular incision taken for this patient. Just for that's how it actually clicks. What I normally prefer is to put a screw in the lateral bone of the condyle. This screw has a hole in it. So what you can do is you can actually pass the stitch through the disc via this screw and anchor the disc like a cap on the bone. This is us fixing the screw. It's a very small screw. It's a 1.3 mm screw, and it does the job for us. And this is how the disc will function under contact. So the moment is smooth. There is an eminectomy which has been performed. The disc is good and moving, and it is in place under load. Total joint replacement, coming to the end section of this, the TMJ ankylosis, tumors, resection. TJR is definitely reserved for the higher form of TMD or TMJ disorders. But we all have to understand that when the problem is in the bone, it is normally TJR, which is the answer. I'm not trying to promote temporomandibular joint reconstruction or total joint replacement, but technically speaking, if you have severe arthritis, avascular necrosis, infective osteomyelitis of the TMJ, there is nothing much that you can do. It is best that before the patient lands up into an anterior open bite because of loss of bone, temporomandibular joint reconstruction helps a lot. Talking about TJR, this is how it is done. So we have a ramal component, we have a glenoid component of the joint. It is obviously done under arch bar, and we need two incisions to pull this off. We need a preauricular or an endoral incision, and we have to support it with a retromandibular or a submandibular incision. And that's how we insert the ramal component as well as the glenoid fossa. The glenoid fossa is made of a different material, and it only allows the rotational movement of this joint, but will add in considerable relief in symptoms. However, it is a prosthesis and will come with its own set of problems. Dislocation being one of the most common problem of a TJR. But when done properly, there are very less chances of that happening. And nowadays, earlier we had only stock implants available for total joint replacement. Nowadays, we have patient-specific implants. You can get a CT scan of the patient and send it across to the 3D mapping, the virtual planning people, and they can construct a patient-specific joint, and we can do a patient-specific joint replacement. However, beyond that, orthognathic surgery, there's a lot of other things which comes into play. Simultaneous joint replacement along with orthognathic surgery, but then that's a little too much to discuss for today, and it's a little out of scope. So let's consider these scenarios now. Say this patient, both gentlemen have this displacement with reduction. Consider both have malocclusion, they both have clicking, but this gentleman on the right has pain, which is probably because of the synovitis and the inflammation of the joint. And this guy does not have pain. It's because he has adaptive capacity of the joint. He's adapted to this problem. How would you treat this patient going forwards? If I was to be put in this scenario with dealing this patient, if it is with reduction and has malocclusion, this patient in my team will first go to Dr. Saurabh. Dr. Saurabh will take a complete history because he's the guy who deals with occlusion in my team. He will take the complete history. He will take the biometrics and everything of this patient, and will probably try to manage this patient initially with a stabilization splint, which should get rid of his pain and the inflammation. But we do this for 6 to 8 months. If the patient does not respond in the first 6 months of his treatment, we will go and perform a level 1 arthroscopy and do whatever is needed inside the joint. Considering a second scenario where there is disc displacement with reduction, but this time there is normal occlusion. The patient is absolutely having no problem with the occlusion, but still having clicking. But this time, this gentleman over here has a parafunctional habit involved. Say he has clenching as a parafunctional habit, and now he has pain and headaches, which has led to synovitis and inflammation of the joint. Whereas this gentleman on the left does not have the pain component because he's adapted. In this, the gentleman on the right, he will have to be managed with his parafunctional habit as well. You will have to manage that as well. So in this patient, only giving a stabilization splint will not be fruitful. You will have to adjunct it with cognitive behavior therapy. You will have to counsel the patient to consciously make an effort to leave the habit. The stabilization splint will have to be made in such a way that it disoccludes all the teeth immediately when the patient performs the parafunctional habit. And sometimes you will also have to resort to Botox as an injection or use anxiolytics in such scenarios where there is an additional central component parafunctional habit. The patient is clenching, it's a central component problem. So you will have to manage this patient at this level also. Consider this patient, he's having, both gentlemen are having disc displacement without reduction, both are having malocclusion, both are having pain. Typically, in a patient with this displacement without reduction, you will hear that they will say that we had clicking, which eventually resolved on its own. But it has not resolved on its own, it has progressed. The disc is completely displaced and now it is not reducing back to position. And you will see that this patient may or may not have a decreased mouth opening. Sometimes they have an increased mouth opening. I mean, not an increased mouth opening, but a normal mouth opening because the stretch is there. Now, since you were talking about stretch, I would like to also point out an important factor that muscles and ligaments, they elongate. Stretch conceptually means when the thing can come back to its original position. A rubber band can stretch. It comes back to its original position. So the concept that there is a stretch and it will return back, no, these things, these muscles, these tendons, ligaments, when elongated, they stay elongated. They don't return back to their original position. So now this patient, typically, if I am to treat these patients, I will go in, the sequencing of this patient will change. I will go in first with an arthroscope, because this is a non-reducing disc. The disc is not moving. It is not a functional disc. This patient on an MRI will have a lot of other problems along with adhesions and a lot of other things. And we will first go and make the joint internally stable. And then this patient will be followed up with my specialist, and he will try to maintain this patient using a splint. So, yeah. I specifically wanted to point dystonia over here. What happens when these patients are completely misdiagnosed and are never diagnosed? What is dystonia? Dystonia is involuntary muscle contraction that causes repetitive or twisting movements. In crux, the main problem of this patient is involuntary muscle movement. He is not doing it, it is happening on its own. Please look at the masseter muscle over here. He is not clenching, it is twitching on its own. For your viewing. So this is a very disturbing kind of a problem when the muscle constantly keeps twitching for the patient. It is actually a very distracting and a disturbing problem. How I dealt with this case is that first and foremost, I got him on stabilization splint. We tried managing this patient conservatively. However, it did not yield much effect. We did an MRI. His joint had some issues. I went in with an arthroscope. I performed an arthroscopy level 1, got rid of the adhesions, got his discs back in position, and I gave 25 units of Botox in his masseter as well as in his temporalis on the ipsilateral side, on the same side. This patient is now symptom-free, but we had to repeat the Botox injection 3 times for him. So what is worth noticing in this is that whenever I gave him Botox, the next time when he came for Botox, the time frame that kept increasing. So the first time I gave him Botox, he came back to me within 6 to 7 months. The next time he came to me in a year. And the last time when I injected him, he came to me after, say, 1 year, 6 months. So the time frame between each Botox injection kept on increasing. And probably now he's still in review, but he does not have the problem anymore. This was one more case, but I do not have the pictures of that patient because he did not consent for it. But he had open mouth lingual dystonia. So what does this mean? That the patient had slurred speech only on speaking. Otherwise, if you neurologically test this patient, how do you neurologically test this patient? You put a spatula against the tongue and you ask the patient to put pressure against the tongue to see whether the tongue is flaccid or not under the control of the patient. He was completely in control of his tongue when you subject him to this test. But as soon as you ask the patient to speak, he lost control over his tongue. This is typically termed as open mouth lingual dystonia, oromandibular dystonia. How I treated this patient, I wanted to perform an EMG first, but for some reason, electrode EMG was not available with me. So I could not do that. But what we did is we performed a Botox injection under ultrasonography guidance. So we took the help of our radiologist colleague. He came, he put in the sonography machine, and under his vision, I went ahead from the lower border of the mandible and we gave 15 units of Botox per side in genioglossus and hyoglossus. The patient was then followed up with speech therapy and he improved. However, it was not complete improvement, but he regained at least 50% of his speech back. He had been in follow-up, but then I lost follow-up as of now. These are the pearls. What I would say that considering the take-home message is that the intercuspal position may not always be the musculoskeletally stable position for the condyles. It is stable because it is it has the maximum number of tooth contacts it provides, said by Occasion in his book. And it is again said by Occasion that the centric position of the condyle is more important than the centric intercuspation of the teeth. Canine guidance, considering that I will be exposed to the dental population, canine guidance is always better than group guidance because it leads only to the temporalis muscle on the ipsilateral side being active. So if you're dealing with myalgia, canine guidance, giving patient canine guidance movement on lateroretrusive movements will always be beneficial. The joint begins to degenerate when the mechanical stress is higher than the adaptive capacity of the joint. Disc function and morphology is of more importance than disc position. Early intervention and minimally invasive method improves prognosis as it will reduce the chances of early local arthritis and preserve disc and bone morphology. Problems arise when the orthopedic instability is combined with forces associated with loading. When I say loading over here, I mean compressive loading. Joint orthopedic instability can initiate chronic musculoskeletal pain that most of the times needs to be dealt with intra-joint procedures. In contrast to traditional concepts of mandating the exhaustion of conservative treatment options, minimally invasive procedures deserve to be implemented as an efficient first line of treatment and should be considered as soon as the patients don't respond to your conservative therapy. This has been elaborated in the articles by Al-Morasi E.A. et al. In 2020 and Murakami K.E. et al. In 2022, who are one of the pioneers in the field of TMJ. And with this, I would like to end the talk saying that you can never diagnose something that you have never heard about. So even if you may not be doing anything, or you may not be able to help somebody by doing that procedure, it is important for every one of you to know that these all things are happening. Because if you know, then only you can deal with it. Thank you. That's me, Dr. Tofiq Bohra, and that was my talk. I respectfully thank you for giving your patience and attention to my talk. Thanks a lot for your time. Thank you. Over to you, Dr. Fortis.
Yeah, it was quite an engrossing talk, I must say. And, should I be on a lighter note, telling jaw-dropping kind of a talk? Too many things to be learned. And I do see some of the senior members of my organization, Dr. Asim, Dr. Salman, Dr. Nadeem. Y'all can acknowledge Dr. Bohra and ask a few questions from your sides. Yes. I would request the members to put on their videos and ask the questions directly to the speaker. If we can request Dr. Bohra to, stop screen sharing, then we can have a panel discussion as well.
Okay. So,
a wonderful speaker and a lovely, presentation. I think it should be kept and revised again and again for people like me to learn again. So I open the session to the speakers, to the participants for the questions and even acknowledgements on behalf of global dental professionals. I find it very humbling to thank you, Dr. Bohra, for agreeing and giving us quite a good information, actually. It was quite overwhelming and good learning. I'm sure people will, follow it up and reach out to you for further.
It is important to understand that, ma'am, what is the need for this talk? The need for the talk is because we as clinicians have to understand how much is too much. Yeah. Okay, you have to draw a line where the patient can be helped and cannot be helped, or where the patient needs referral. So that's something which has to be understood. And yes, you have to look at the joint holistically. You cannot just keep treating only one thing at a time.
So being
Dr. Abu Bakr, thank you, sir.
Being associated with an orthopedic hospital, I more appreciated all the more on the talk, actually, because a lot of spine surgeons and orthopedic doctors do refer us cases relating, it gets referred and finally they localize and they suggest it has to be sought by a maxillofacial surgeon or the dentist for the needful. So that is when...
So Absolutely, ma'am. Orthopedics, and we ourselves sit with a lot of orthopedics. There's a lot to learn from them actually, because they talk about it from a different perspective. See, we come from the dental background, including me. We all come from dental backgrounds. So for us, it is occlusion because that's what we know. But then it is important to look at it in a complete, comprehensive manner. And orthopedically, 100%, it's a joint. And in fact, it's a very complicated joint. It is more complicated. It is a compound joint as per occasion, if you go to
Yes.
see.
Yeah.
Thank you. Thank you, Dr. Salman Pasha. Thank you. Thank you, Dr. Musharraf. Thanks a lot.
So what is the approximate recovery phase after the joint replacement in case, I mean?
So, ma'am, normally speaking, what we do over here is that the patient is on IMF. Okay. And once we remove the IMF, that is by the third or the fourth day, the patient goes on aggressive physiotherapy. This phase of physiotherapy will be continue for say around a month, where the patient will follow. I mean, yeah, if you want to know the cycles, even if you have to put your patients on physiotherapy, it is necessary. How I follow is that you perform the mouth opening exercises, do 20 repetitions 4 times a day. That's what we follow over here. So
yeah, I think we have some questions and some
yeah.
thank you messages. So
Thank
Dr.
you, Dr.
Asim,
Basha. Thank you, Dr. Tawseef. Dr. Abu Bakr has a question. How much, according to your experience, is orthodontic treatment detrimental to TMJ? Detrimental as in detrimental in spoiling the TMJ or in affecting the TMJ, you mean to say, Doctor? However, I will answer it in a general perspective. Orthodontic treatment, normally, yes, we do prefer orthodontic treatment. But what happens is that, okay, so when we look at occlusion, there are two types of occlusion therapies. One is reversible occlusion therapy, and one is irreversible occlusion therapy. Okay, since we are on the point of occlusion, I would like to mention this. So, orthodontic and removing occlusal interferences comes under irreversible occlusal therapy. Giving a stabilization splint is reversible. You can always, if the patient is not responding, you can always take it off. Why am I explaining this? Is because once you expose the patient to permanent occlusion changes, you are not sure whether the patient will relapse or not. But if you have achieved the harmony with a reversible occlusion therapy, then you can go ahead and perform an orthodontic treatment and try to achieve that in permanent occlusion. That's how orthodontics can be integrated into TMJ. Yes, it is. Having said that, during the orthodontic treatment, the patient will not be allowed to wear the splint. So yes, that's where you have to be a little tricky about it.
Yeah. Dr. Asim says TMJ has always been a mystery. My question is role of nutrition in TMD, as nowadays we are using glucosamine. What is your take on this?
Nutrition. Okay.
Glucosamine.
I do not have particular knowledge about nutrition in temporomandibular joint disorder. However, if you ask me about what they should have dietary habits, I would say I mean, that is what we deal with, but we put them on soft diet. But nutrition per se, I'm sorry, doctor, I'm not aware about this nutrition aspect of it.
So Dr. Tabassum wants to know if, you give us the permission to contact you. I think the whole 100%. Idea of getting collaborated with Dr. Bohra was for global dental professional members, benefit, vice versa. So I'm sure, he obliging for giving us a talk from his busy schedule itself speaks a lot. So I'm sure Dr. Tabassum, you can approach him as well.
Yes, Dr. Mohammed Hafiz has a question. Can you enlighten us about TENS procedure? Yes. So yes, TENS can be used. So consider a case which comes to you with probably say that you have performed a Mahan's test and he has or he or she has pointed on the same side and you have concluded that, okay, it is purely muscular. It has nothing to do with your joint per se. And you are going ahead with a splint for him or a stabilization splint, you can use TENS. TENS by full form is trans-electric nerve stimulation. By definition, what it does is it basically relaxes the muscle by passing a small amount of current. And yes, you can always use it to reduce muscular hyperactivity. But I would say that a TENS procedure is best performed in combination with an EMG. So you can take a EMG recording first. You will get muscle hyperactivity, and then you can go ahead and perform a TENS procedure, and then again, have an EMG test done. However, nowadays I am aware because I have seen my patients coming with a small 2-channel TENS device. It is available on Amazon, so they can do it at home. So it's become really simple. So yes, you can use TENS, Dr. Mohammed.
Dr. Hafiz has a question, would like to know about the
stabilization splint. Yeah, more about stabilization. What are the key points to it? So for me, stabilization splint is something which it's a hard splint. It is on the maxilla. And why on the maxilla? Because maxilla is the point where the mandible is the moving portion of the head and neck component, and it comes and it occludes with the maxillary teeth, and that's where the stabilization needs to happen. What Dr. Saurabh, it is not technically you say my specialty, but then I would like to say that what I look for is complete disocclusion. That's what we look for, and we see the feedback of the patient to the splint. So yes, that's how it is. Disocclusion is what you want to look in a stabilization splint. And yes, obviously, the patient should be comfortable. So see, normally what we follow is it takes 3 to 4 days for the patient to become comfortable with the stabilization splint. But if the patient still is complaining after 10 days of using the splint, then you need to understand that, okay, it is doing good. You may have intended something else, but something else is happening. So you need to revisit the splint. Now we do that. It happens. It is more common than you know.
So Dr. Nadeem has a question. He's one of our organizing member as well. Yes, sir. Dr. Nadeem.
Assalamu alaikum warahmatullahi wabarakatuh, Dr. Bohra.
Lovely presentation. On your video, sir. Can we have a video on?
My audio? Yeah,
yes,
thank you.
Yes.
Yeah, lovely presentation, Dr. Bohra, and Jazakallah khair for the enlightenment given on the TMJ issues.
Thank you.
I have few questions combined together.
Yes.
Most of the time when we have TMJ patients who are walking into the clinic, they're first encountered by the GP doctors. So that is the time we try to coordinate with the oral surgeons, and we write for an OPG or a TMJ open and closed view. So and we try to coordinate with the oral surgeons. So basically, the first line of treatment, what the oral surgeon suggests, is to check for any kind of interferences and give a splint. So we blindly start with the splint. When the pain does not come down, so these are the patients who try to get in touch with the ENT specialists. So my question is, most of the TMJ procedures are carried out by the ENT specialists, but not by oral surgeons. If carried out by the oral surgeons, are all oral surgeons trained to do TMJ arthroscopy? That's first thing. And second question is, if they are trained to do, it should be done in the hospital setup, or can it be done in the local setup, like under local anesthesia also? And third thing, is counseling required before start of the treatment or after finishing the treatment? Jazakallah khair.
So coming to the first question, sir. So the first question by you was that when they are referred, the ENT start performing their treatments, and when they are referred to maxillofacial surgeons, they ask to perform the occlusal interference in the splint, and that's how it goes. And are all the maxillofacial surgeons trained in arthroscopy? Am I right, sir?
Yes, exactly.
So to answer the question, sir, as of now in the country, there are very few oral maxillofacial surgeons trained in TMJ arthroscopy, because for a simple reason, sir, that over here we do not have that number of courses as of now, but they are coming up with it, and we will be training the future crop of oral maxillofacial surgeons. It is open to all the oral maxillofacial surgeons currently, but the problem is that doing it just once and twice does not make you proficient at this. Frankly speaking, I'll be very frank with everybody out here. We all are doctors. The first 10 to 15 arthroscopies of mine were off and on. I could see sometimes and I could not see sometimes. It is very difficult to go through that steep learning curve. And for that main reason, TMJ Mini Residency is by far the most comprehensive course I have come across, because there are modules and they give you those heads to practice upon, and they take you step by step from level 1 to level 2 to level 3. However, we do not have that exposure in India yet, but it will be soon arranged, and we are in the process. And more and more surgeons, oral maxillofacial surgeons, will get trained in this. But for that specific reason, sir, this talk was conducted to understand the scope of arthroscopy, so that more and more people can get encouraged to learn the skill, because it is a skill, sir. At the end of the day, I have known a lot of oral surgeons supporting it, and a lot of oral surgeons not supporting it because they cannot do it. But then that does not deem the procedure invalid. It still stays valid. You may not know it well, but so learning it is the answer to it. So yes, that is one part of it. The second part of your question, could you repeat it, sir? I just forgot.
When it comes to the counseling of the patient, when the patient is under high stress, so yeah, so do you counsel first, relieve the patient of the stress and start with the TMJ treatment?
Yes, sir. So counseling, majoritarily, sir, when we are talking with these patients, counseling is mainstay. So in my practice, whenever the patient comes to us, for a fact, we all know over here that this problem is more prevalent in females as compared to males, if you consider the prevalence of TMD. So most of the times, these are young females who have just married and they are sitting in front of you. They have gone, as you rightly said, they have been to the ENT. From ENT, they have been to the neuro. From neuro, they have been, sometimes these patients have been to psychiatry department, and they have come because why are they exposed to psychiatry? Because what they perform is they will perform probably an OPG. Okay, they might go through a CT ear. The ENT may perform an otoscopy. Okay, then MRI brain. Technically, you will see these patients having these reports. They will always come to you with these reports, and all the reports are normal. So now the family members are saying that it's all in your mind. So these patients require a little form of counseling. And yes, during our counseling, we are extremely, extremely careful of the words we use. We do not commit to any form of treatment. We explain the patients that this is a chronic problem. It has not come overnight and it will never go overnight. It is a process that you follow. And committing to the process is the success over here. If you be impatient and abandon the treatment, because see, I say it very frankly in my counseling with the patient, excuse me, that my job is the easiest. I will go inside the joint, I will treat the joint, and I will come out. It is the aftermath of it which matters. That is the healing phase of your problem. And if the patient is in initial stages, then we do explain the patient that conservative treatment is how you go ahead. And if you do not respond, then we will go ahead with the surgical things. But yes, in my case, I have an advantage because I perform arthroscopy. So what happens is, actually the problem is that in the previous years, what used to happen was conservative therapy or directly an open joint surgery. There was nothing to bridge the gap. But now we have this procedure which can efficiently bridge the gap. Not only bridge the gap, can also allow you to perform a lot of other things where you can avoid the open joint procedures. My open joint procedures today have come down to almost 90%, 10%. 90% of my cases, I deal with them via an arthro. So yeah, am I missing any of your questions, Dr. Nadeem Ahmed?
Yeah. Yeah, I think the general anesthesia and chair side, which.
The general anesthesia and chair side.
Yeah.
So I do not advocate local anesthesia. I have performed it under local anesthesia, but you do not achieve that kind of muscle relaxation to perform it in local anesthesia. So in my opinion, I would say that you may use that. I have colleagues in the western side of the globe who are using sedation, basically a combination of a cocktail of remifentanil plus propofol and performing these cases. But somehow over here, anesthetists are a little reluctant of going through that. So they will always promote general anesthesia. And yes, general anesthesia is a comfortable scenario because if you have learned a skill and you are new at the skill, you may want a little more space to work. And general anesthesia gives the surgeon that mental relief as well. You're not constantly counseling the patient that, okay, now I'm going to put the trocar, now I'm going to put the scope inside you. So it takes that out of the equation. So you're better off performing it on general anesthesia. Thank you for these questions. They were good questions. Thank you.
I just have a last question, Dr. Raheja. Can I ask? Or can
Yes, yes, sir, please.
Yes, yes, please.
Yes.
Yeah. The question is, Dr. Bohra, what
Yes.
I fail to, understand in my practice on a long span of practice, I have lost many of my, TMJ patients who have come to me. I have failed to treat them in proper manner because of the diagnosis given by me and improper treatment protocol given by my other specialists. So what has happened? They have gone to the ENT specialist. They have gone to the ENT specialist, got operated. Uneventful problems have taken place after the surgery.
Sir, if I would, what do these ENTs perform? What form of surgeries do they perform? Do they perform open joint surgery?
Yeah, TMJ, the disc, they consider themselves as, this, what is that? I don't know what is the terminology, what they use, honestly speaking. They just try to get into the TMJ space and try to recontour the TMJ joint, the disc joint.
Okay. Okay.
So after the procedures, still people have failed to, come down with the problems and ultimately gone to a neurologist and they have landed up with antipsychotic drugs. So was it necessary of a simple problem which could have been cured by proper diagnosis? As you just mentioned few minutes later, there are not much specialists who train under TMJ arthroscopy. So are we at one point, are we liable to push these patients to such extreme measures?
Sir, performing an open joint surgery does not really guarantee relief. It is the misdiagnosis which is the problem. So as you rightly said, that when it gets misdiagnosed or you diagnose it in a different way and then you try to treat with the extreme measure first, but do not follow it up. So now I would say that if the ENT is performing an open joint surgery, is he following up with proper load distribution? Because that is the primary requirement of a joint. After every knee surgery, the orthopedic will tell the patient to use a walker because that's the way they initiate load sharing. Are they doing that? Because if they don't do that, then there is no point going in and removing the embenectomy because that's as good as just increasing the joint space. Getting the disc back in position and asking the patient to function. At that point of time, if load sharing is not done, the patient is going to relapse. So we are treating the patients at three points where the said specialist is just going and treating the joint. We cannot treat like that. Being maxillofacial surgeons, we have to treat the joint. We have to manage the occlusion because yes, that's the place where the bite force is developing. You cannot just throw it out of the window. And the muscles. So the thing what I say is it's a triangle. When you manage the joint and the occlusal or the load management is done properly, the muscles they realign. The hyperactivity which was once there, it comes down because you have relieved them of the load. So that's how I think everybody should approach a problem to understand where the patient. So there are two things to understand. First, it is to understand which stage the patient is coming to you. If the patient is already got very complicated, conservative treatment will always prove right. But I personally do not follow any irreversible conservative treatment. That means removing occlusal interferences, we don't do that. Going directly for an orthodontic treatment when you see a crossbite or a scissor bite, we don't do that. What we do is we give just a stabilization splint. Stabilization splint is not my forte, but the centric position, as I said, is more important. So Dr. Saurabh, my counterpart who manages this, puts the patient in the most centric position that is possible. And then we let the patient be. And we just manage the patient with symptomatic treatment. That will include medicines. That will include some injections from my end if need be. And then we observe the patients. If these patients do not respond, then yes, performing an arthroscopy does help these patients. Why? Because somewhere or the other, there is going to be joint inflammation. There is going to be some component of adhesions. So you can go in, you can do that, you can have a sweep, just going inside the joint and sweeping through the joint with the scope gets rid of the adhesion. So that itself proves beneficial to the patient. Now, when you club it with load distribution management, the patient responds much better. Because that arthroscopy of yours will give the confidence to the patient that I'm improved. And then they even comply better, because yes, that develops trust in the patient. He has already been to multiple specialists before coming to you. He feels that what are you going to do new for me? So that trust deficit has to be filled somehow. So yeah, that's how did I answer your question rightly?
Yeah. Jazakallah khair. Thank you for answering.
Thank you.
Dr. Hafiz asks for ideal thickness of splint and the correct method to record this.
So it would be in a adjustable articulator. You should take it in a adjustable. There are semi-adjustable and now articulators, what we know as the phase bow transfer. So they do a phase bow transfer in a proper adjustable articulator where they can see the lateral movements. And I think the thickness that he maintains is around 2 mm at 2 to 3.5 mm thickness is what he maintains.
Dr. Gibran asks for if a patient comes in with unilateral clicking with no symptoms, how should we manage such patients? Do we have to do anything to prevent it from deteriorating, or no treatments required?
So a unilateral click is normally a scenario where probably the patient would not have much of a problem if it's just a unilateral click, but you will have to keep this patient under constant follow, because his unilateral click very early will convert into a bilateral click and then will convert into a progressive arthritic stage. So it has to be, so there are two things that I would follow at this stage. One, keep a close follow-up with this patient. Second, if at all he is coming to you with pain, then you can try going ahead with a conservative management. That is a stabilization splint at this stage also, because there is no harm. You will only help the patient. He will, stopping the deterioration is also helping the patient. So you can go ahead with conservative management. Personally speaking, giving steroids in the joint is a little less appreciated nowadays. Because steroid, yes, it will bring down the inflammation of the joint, but it also impairs healing. So steroid injection is not something which I regularly do. I mean, just for purpose of a study, we had injected RL into the joint of a patient instead of steroid. The patient responded in the same way how he would have responded to the steroid. So technically what I found is that from a research standpoint, encephalating the joint gives more relief to the patient than the steroid itself. So that is more important, I guess. Maintaining joint space is what I mean. Thank you, Dr. Nadeem, for your questions.
I guess I have nothing but, taking the path less traveled. Dr. Tofiq is very appreciative, and coming and sharing it with us is even more appreciative. I'm, kind of indebted and humbled. So I thank you on behalf of global dental professional organizations. And I'm sure you'll have a lot of, queries at your inbox, since you're sharing and giving the liberty of contacting you. So
Please do.
okay. So thank you so
I would
much.
love
Thank
to
you all the
answer it if I can
participants.
help.
Yeah. Okay. Thank you. So I end the session
you.
now.
Thank you,
so
ma'am.
much.
Thank you for
Thank
your patience and listening. Thank you.
Thank you.